I'm Rick McGuire, Executive Editor of CardioSource WorldNews. I'm with Dr. Jonathan Steinberg, and he is of Columbia University College of Surgeons. We're talking about the federal audit of ICD implants, lessons learned. Jack, April 3rd, 2012. This is a special article, and we're taking a look at ICDs, obviously, in this federal audit. Talk about the audit at first. What is it?
The Department of Justice initiated a civil investigation at a number of institutions around the country related to possible coding violations for ICD implants. Our local institution was one of those, and as such, we had to respond to a Department of Justice audit that looked into the appropriateness of ICD implantation at our center.
I mean, there's been some concern whether or not people who truly are by the guidelines eligible for an ICD, whether they're getting it, and the other side, are people getting it who really aren't qualified under the guidelines? What did you find?
Well, I think you're right. I think at one end of the spectrum are people who clearly need it and don't get their device. That was not the subject of this inquiry. What is also happening at times are people who are getting the devices who may not require them, who may not benefit from them. And that's the focus of the Department of Justice audit. It turns out at our institution, when we did a detailed analysis of the patients who were identified by the Department of Justice, we found that the vast majority actually required or could benefit from the ICD, but technically violated the national coverage determination put out by CMS. And thus, there was a coding violation, but best clinical judgment dictated that these patients should receive a device.
So guidelines were followed, but the paperwork or the computer wasn't indicating that it wasn't correctly coding everything.
Yeah, it actually turned out to be a little complicated. We found about 5 categories of patients that made up the bulk of the patients identified by the audit. And these categories, we believe, indicated that the patient could benefit, but they fell within the cracks, so to speak, of current NCD details.
So for the most part, it looks like the indications are being paid close attention to by the clinicians.
Yeah, at our institution it turned out yes, and now we realize perhaps the charts did not document them as well as they should have, or perhaps coding issues came up later where a coding violation may have occurred but the clinical indication was met, and those things need to be dealt with prospectively.
Is there any lesson learned that may apply to other institutions?
Yes. There are clearly a few lessons. One is, as we've heard over and over, documentation is crucial. If your patient falls neatly into any of the approved categories, then that things will work very smoothly. But as all of us know, the nuances of clinical practice, it is oftentimes true that they don't fall neatly into one category or another. If that's the case, make sure there is vast documentation in the medical record so it's available to any auditor, internal or external to the institution. Secondly, you have to make sure your coders are aware of some of these subtleties in coding. You cannot code an acute MI at the same time as you're coding an ICD implantation. Those will set off alarms, and one of them may not be an accurate diagnosis or procedure that needs to be coded for reimbursement. So that needs to take place within the institution. Lastly, we find there are certain circumstances that actually are just not covered by the NCD, but advances have taken place since this NCD was issued. Remember, the last time it was updated was 2005. So there are many circumstances that are not accounted for by the NCD. And the Department of Justice has acknowledged that there are circumstances that don't quite fall into these guidelines, and they will be sensitive to that as long as you've documented it very carefully in the chart. And we also have done some internal things. We peer review each other's procedures to make sure they're accurate. We have special forms now that are completed before an implantation to make sure all inclusion-exclusion criteria are dealt with. And if there are mitigating circumstances, these are clearly set forth in the chart.
I think it's really encouraging that the clinical decision-making is strong. I mean, I think that is good news.
I agree. And we were able to look at our cases, and about 85% of them we felt were justifiable on clinical grounds, although they may have violated technically the NCD.
Right. Well, the April 3rd issue of the Journal of the American College of Cardiology is where you will find this particular special article, The Federal Audit of ICD Implants, Lessons Learned. Jonathan Steinberg, thank you very much for joining me. And read the article summary in CardioSource World News. I'm Rick McGuire.